good to see everybody here. This session is the ISDS and IASMEN main session on metabolic management for major surgery. Now, you might wonder, what does nutrition and HPB surgery have in common? Well, we've all taken care of people who've had a complication post-op, and you need to feed them. Unfortunately, we've probably all operated on somebody that we shouldn't have operated on at that time because they were malnourished. How do we evaluate that? How do we deal with the problems post-op? And what's the role of the microbiota in all this, which is the hot topic now, and we have a talk on that. So we're going to get started. My colleague, Dr. Nabeya, is going to introduce the first three speakers, and I'm just going to show you how to work the things up here. So, Professor.
Thank you very much. So we will start this session. I will introduce the first three speakers. The first speaker, Professor Toshimi Kaido from Kyoto University in Japan.
Okay.
He's one of the experts of liver transplantation. Okay, Professor Kaido, please give us the lecture.
Thank you, Professor Nabeya and Professor Sarr. Good afternoon, everyone. It is a great honor for me to have an opportunity to speak today. Let me first introduce my question or experience as a surgeon. When we first meet a patient, if the appearance is good, the outcome is also usually good. But if we meet a patient with such appearance, even if we perform perfect operation, sometimes outcome isn't so good. Why? Is the impression? Don't you have the same experience? So in this presentation, we'd like to clarify the reason objectively. As you know, liver transplantation is an operation to remove such liver failure, liver cirrhosis, and to replace with whole liver or partial liver. So introduction of ELAS was considered to be difficult. Here is the nutrition status in patients undergoing liver transplantation. Gradually worsened due to liver cirrhosis and gradually improved by operation. So when patients undergo liver transplantation, here, liver cirrhosis patients undergo liver transplantation in the worst nutrient status. So the aim of the study is to introduce the significance of nutrition and in ELAS-based peripheral management. And finally, we'd like to introduce impact of body compositions in liver transplantation. First topic is significance of nutrition. Here is our survival after LT in Kyoto University more than 10 years ago. You can see here, 1 year survival was 82%. So liver transplantation was called high-risk surgery. Next, we investigate the cause of death in early mortality. You can see here, infection was the most frequent cause, such as peritonitis, cholangitis, and pneumonia. Then we did this further analysis for post-transplant infection. Formerly, liver transplant patients were prone to infection and had malnutrition, but the correlation between infection and nutrition was unclear. So, in addition to patient factor like this, we added two nutrient factors. Perioperative body cell mass, I will introduce in the next slide, and perioperative BCA lineage nutrient mixture, and graft factor and time of blood loss. Here is the body cell mass. We can measure BCM within 2 minutes. This is sum of intercell fluid and total blood protein. So it is good index of nutrient status even in patients with liver cirrhosis. If low BCM, it means malnutrition. Let me show the results only. How about risk factor of sepsis? Surprisingly, not child PUC, not mass bleeding. Two factors are related to nutrient factor. As I mentioned, perioperative malnutrition and absence of perioperative BCA in the mixture were independent risk factors for sepsis. So I considered perioperative nutrition intervention is very, very crucial. Do you know the organ or tissue with some of nutrient fluid and total blood protein enriched? This is muscle. So in this analysis, we found infection and nutrition of muscle were very, very closely correlated. Next topic is ALS-based perioperative management. You can see here, there are two factors of nutrition management. One is accurate assessment, the other is adequate intervention. For surgeons, it is impossible. Dietitians are indispensable. So we started accurate assessment with dietitians. You can see here, there are many nutrition parameters. For example, BMI and HCMC is not available for patients undergoing liver transplantation. Lipids protein, not available. Albumin, not available. So there are one is a new nutrient parameter are necessary for evaluate nutrient parameter status for patients undergoing liver transplantation. So we introduced body composition analyzer more than 10 years ago. This is a practice of measurement of in-body. If you look at the right upper panel, a man with smile, who is he? He's me 11 years ago. We can get many data within 1.5 minute, including skeletal muscle mass and BCM. More better, if we put patient height and sex in this apparatus, it automatically calculates patient standard SMM. So we forecast sarcopenia. As you know, this is a coined word. Sarx means muscle in Greek, and penia means decrease in Greek. So sarcopenia means first decrease in muscle. But after that, two groups advocated new definition. In addition to muscle depletion, low muscle power or decreased physical activity. So we first measured muscle mass, skeletal muscle mass, SMM. Here's the distribution of muscle mass. So we divided the patient into two groups, sarcopenia group and non-sarcopenia group. Surprisingly, patients with sarcopenia had worse survival compared with patients without sarcopenia, especially early death due to infection. Next, we'd like to little bit mention about adequate intervention. So we try to introduce ILAS into liver transplantation. As you know, ILAS is an abbreviation of Enhanced Recovery After Surgery proposed in Europe, almost similar to fast-track surgery in US and ESSENCE in Japan. As you know, among 17 elements, nutrition parameters play important factors. Let me talk about, in brief, in preoperative nutrition. ISDS guidelines asked, how about the indication of preoperative nutrition treatment? For this, they recommended that patients with severe nutrition risk benefit from nutrition support for 10 to 14 days prior to major surgery with level A. So, liver transplant patients just apply to this category. Which one is favorable for nutrition? As I mentioned, BCA is very important. So, we introduce less late evening snack. One pack we administer between lunch and dinner, and the one more pack we administer at 10 p.m. So glycogen storage recovers, so starvation will disappear. Much more, it is useful for sarcopenia because it includes BCAA. Let me talk about preoperative fasting. Formerly, in all over the world, meal until dinner the day before operation, and water until 10 p.m. But current fasting rule has changed. Meal until 12 p.m. the day before operation, drink until 2 hours before anesthesia. Regarding post-operative nutrition, ISDS guidelines ask, is early food intake or enteral nutrition following the surgery beneficial? For this, it recommends that placement of a new catheter stomy and tube feeding should be initiated within 24 hours after surgery with level A. So, in our institute, for liver transplantation, high-level cancer, or pancreatic cancer with malnutrition, we routinely place tube stomy, and we start early nutrition within 20 hours after surgery. But in some patients, small intestine does not move quickly. So, for these patients, we administer Campo Daiken-Chuto. Daiken-Chuto consists of these 4 elements. So we hypothesize that if we administer Daiken-Chuto after liver transplantation, it promotes bile movement and early oral enteral food intake is possible, so it leads to early recovery. So we perform an RCT. So it is the first RCT combined with liver transplantation, ELAS, and CAMPO. This is the result. If we administer the Akinchuto, 1.7 times higher increase rate of caloric intake. Then which formula is favorable for post-transplant nutrition? ISPEN guidelines also ask which formula should be used. For this, the guideline recommended immunomodulating substrates with grade A. But there is many substrates. Among them, we chose a diet enriched with whey hydrolyzed peptido. Whey hydrolyzed peptido, as you know, has various beneficial abilities, including anti-inflammatory effect and antibacterial effect. I consider that it is beneficial for post-transplant infection. You can see here, patients who received whey protein had significantly lower incidence of bacteremia. Here is a summary of a perioperative nutrient therapy. We assess nutrient factor on admission, and we do a tailor-made nutrient therapy with dietitian, like this. And after operation, like this. Rehabilitation is also important. The Harvard's effect of perioperative nutrient therapy on survival. This is a figure I mentioned above. For sarcoma patients, we divided who received nutrient therapy and who did not receive nutrient therapy. You can see here, patients who received nutrient therapy had 40% increased survival compared with patients without nutrition. But in this cohort, we did not do perioperative rehabilitation. So this is a new strategy. We assess sarcopenia on admission and select patients with sarcopenia. Then we focus nutrient therapy for such patient, then prognosis will improve. Now, if we do perioperative rehabilitation, prognosis will much more improve. Regarding perioperative rehabilitation, breathing muscle and swallowing muscle and lower extremity. Here is our new paper. If we perform rehabilitation for patients undergoing liver transplantation, knee extension strength and 6 minutes walking distance were significantly improved, even for patients undergoing liver transplantation. As for post-rehabilitation, we start as soon as possible from POD1. We are additionally performed RCT recently to examine the efficacy of HMB. HMB, as you know, is the metabolite of leucine for after liver transplantation, a pilot study. This is the RCT examining the effect of nutrition with rehabilitation. Surprisingly, patients who received HMB did not decrease SMI after operation. Regarding grip strength, significantly improved compared with patients without HMB. We are now writing a paper. Much more, post-hospital stay was significantly shorter in patients with HMB. Then it contributes to ELAS. Last topic is body composition. We measure body composition using plain CT Lambert level, muscle quantity, muscle quality, and visceral adiposity for patients all HBP surgery. Regarding muscle quantity, using CMI like this. As for muscle quality, evaluated by IMAC like this. And as for visceral adiposity, using VSL like this. The green area divided by blue area, very simple. How was the impact of body composition on survival after LDT? 250 patients were enrolled in the study. You can see here, patients with low SMI had worse survival compared with patients with high SMI. Similarly, patients with low muscle quality had worse survival. Moreover, patients with visceral obesity had worse survival compared with visceral obesity. Interestingly, these three factors has only weak correlation, so three factors were independent risk factors for survival after liver transplantation. So this is the answer of my previous question. Such patients maybe had without abnormal body composition factor, but such patients had at least one abnormal body composition factor. So I think appearance is very important for patients. This is formally our impression, but in this analysis, we first quantify the reason. Finally, we examine the number of abnormal factors after survival after LDT. You can see here very, very clearly stratified. If patient had no body factor, abnormal factor, 1 year survival 98. If each one 78, if each two 60, if all 41. So we consider for patients with 1 or 2 abnormal factor, we did aggressive rehabilitation and nutrition. But for patients with 3 abnormal factor, we recommend disease donor transplantation. And during waiting time, we do intervention. So abnormal factor 2 or less is now our indication for heredity. So we did validation. As I mentioned, formerly, the overall survival 1 year 92%, so high risk operation. But currently, it improved to 1 year 99%. So in Kyoto University, liver transplantation is not high risk operation, but low risk operation, very safe surgery. So in conclusion, if nutrient status and body composition are impaired, it leads to poor prognosis. But if we perform nutrient therapy or and perioperative rehabilitation, prognosis will improve. Finally, I'd like to emphasize again, in the institute, liver transplantation is not high risk, but low risk operation. Thank you for your attention.
Okay, thank you very much, Professor Kaido.
Well, wait, no, let's. Does anybody have a question? Well, I might ask you one thing. There have been a lot of papers on prehabilitation in HPB, colorectal, so forth, that have not shown a benefit.
Yeah.
I like your approach. How often can you take somebody with severe cirrhosis from the high risk to the low risk group in 2 weeks? Is that common?
Yeah, thank you for the question. We, after admission, we only perform after admission, but we ask the doctor for previous hospital, we ask to do rehabilitation and nutrient therapy. Then it means about a few months time to intervene rehabilitation, actually.
Quick question.
Yes.
In follow-up to the prehabilitation, in Japan, I've seen some data in randomized trials about inpatient prehabilitation. Is that what's happening in Japan, that patients are in the hospital before their surgery getting their exercise and physical therapy?
Thank you for the question. Of course, it depends on hospital and hospital. So not all hospitals do prehabilitation, but we do like to perform prehabilitation for patients undergoing major surgery.
Maybe social situation, right? By the way, how do you decide the length of prehabilitation?
Yeah, for
In
patients
each
with
patient.
LDLT, yeah, as long as possible. But as you know, not so many duration patients can admit them before operation. So, as I mentioned, I asked the doctor for previous hospital to do rehabilitation. So it takes about a few months we can do rehabilitation.
Thank you very much.
Yeah.
Please sit here. Okay, so the next speaker, Dr. Pauli, Puolakkainen from Finland. His title is Control for Microbiota in Biliary and Pancreatic Procedures.
Where is yours? Up there. Okay, pointer, back and forth.
Okay, should do it. Okay, thank you,
Could you give us a
Mr.
lecture?
Chairman. Ladies and gentlemen, it's great to be here in this great meeting. I have nothing to disclose, and what I've tried to do briefly during the next couple of minutes is to give you some kind of idea about the controlling of microbiota in biliary and pancreatic procedures. I'll cover some general aspects going to the antibiotic prophylaxis treatment, and then I'll show you some international guidelines and local institutional protocols, and in those I will deal with those of Helsinki University Hospital in Finland. The first thing, of course, in this procedure is to take care of the personnel, their hand hygiene, gloves, using masks and clothing that should be monitored, and the checklists that have been in use in our institution for a long time now. They are very helpful in reminding all the pre-op medications and so forth, like the prophylactic antibiotics. As far as the patients are concerned, the detection and handling and optimizing factors leading to elevated risk of surgical side infections, SSI, and other infectious complications should be taken into account, looking at the comorbidity of the patients as well as medications, and obviously also the perioperative hypothermia should be avoided as much as possible. Controlling the microbiota in the surgical instruments and endoscopes is highly important, and it's actually highlighted in the ESCE guidelines that came out just a couple of years ago. So you'll have to have competent personnel, detailed instructions, cleaning equipment, and the cleaning steps that should be clear to everybody. And the background for that is obviously that you have to have a microbiological surveillance of endoscopes to prevent multi-drug resistant infections. And there is several guidelines giving instructions about this out there right now. If we talk about the biliary infections, it's obviously very beneficial to know what are the microorganisms mostly causing the infections. E. coli, Klebsiella, Enterococci, and some anaerobes are mostly involved. Rob and his colleagues were looking at 1,400 ERCs a couple of years ago, and he was able to show that up to 71% of the bile samples were positive. And the most common species were Enterococci, E. coli, and some other species. ERCP, how often do you see infections on that? Nelson was looking at the high number of ERCPs and showed that if there is no obstruction, it's about 6.4%, but it triples in cases with biliary obstruction, which is highly important, obviously. Cholangitis and sepsis after ERCP up to 3% in early studies. And Bai was looking at 7 different trials going up to 1,400 patients and was able to show failure in decrease of the incidence of cholangitis with the use of antibiotic prophylaxis. And pretty much the same kind of idea has been shown in several studies. So the conclusion of the ERCP is that the routine use of antibiotic prophylaxis is not recommended by any of these guidelines currently. However, if you have a patient belonging to a risk group like those with liver transplants or a failure in the endoscopic treatment of biliary obstruction, namely, for example, incomplete biliary drainage, then antibiotic prophylaxis is indicated. And in our unit, levofloxacin is in use in those cases, and it is continued after the procedure as required. Looking at the endocarditis briefly, the ASGE suggests antibiotic coverage only with patients with high-risk cardiac conditions and those with established GI infection with Enterococci. Moving to the gallbladder, looking at an elective LCC laparoscopic cholecystectomy randomized study. The beginning with the SSI are rather rare after LCC, and the antibiotic prophylaxis did not affect the outcome of the patient, so thus the antibiotic prophylaxis is not needed for elective LCCs. However, in cases, if suddenly you have a perforation of the gallbladder during the operation, you might consider prophylaxis, which is in use in our institution. Acute cholecystitis is pretty straightforward. We are mostly talking about treatment more than prophylaxis. We'll start the cefuroxime 1.5 grams 3 times a day at the time of the diagnosis prior to the operation, and it's continued depending on the type of the surgery, whether there's perforation or some other complications as required. Moving to the biliary tract surgery, we use in our institution prophylactic antibiotics, ceftriaxone, metronidazole, 1 gram less than 1 hour before the operation. And it is discontinued after the operation unless there are specific indications or the duration of the operation is more than 4 hours. Looking at the biliary tract reconstructions, one idea obviously is to have a pre-operative bile culture targeted administration of the prophylactic antibiotics. And Okamura was able to show a better outcome of the patients where this idea was applied. Briefly, the treatment of cholangitis according to the renewed, updated Tokyo guidelines involves empiric therapy, and once you get your results from the lab, then you can de-escalate them accordingly. And there is a wide variety of options to be used in these patients, and obviously a multidisciplinary approach can be recommended in these cases. And usually the duration of the antibiotic treatment is up to 4 to 7 days. In general, the duration of the antimicrobial prophylaxis, the principle is to keep it as short as possible. So the shortest effective duration to prevent the SSIs. And sometimes the ideal duration is actually not known, but definitely not more than 24 hours. And there is no data to support the continuation of the prophylaxis until the drains and catheters are being removed from the patient. Endoscopic ultrasound, rather useful and widely used method for taking biopsies. ESG recommendation is not to use antibiotic prophylaxis in cases of solid masses or lymph nodes. But if we are talking about cystic lesions, it's a different ballgame. So in those cases, ESG suggests the use of antibiotic prophylaxis and suggests the use of fluoroquinolones or beta-lactam antibiotics in those cases. Moving on to the pancreatic surgery, in general, as in the ERAS guidelines, the pre-op biliary stenting in patients undergoing PD only in selected patients, and the same principle is applied also in the ESG guidelines. So only for patients with cholangitis, severe symptomatic jaundice, delayed surgery, or before the neoadjuvant chemo in jaundiced patients. In pancreatic or Whipple patients, it's in stented patients, Gavazzi was able to show a effect by using the anti-enterococcal activity antibiotics. A recent study by Fong and his colleagues looking at the large-scale multi-institutional study again revealed the idea that the intraoperative bile cultures are beneficial to aim the right antibiotic for the prophylaxis. So the prophylaxis can be carried out accordingly. Looking at still the Whipples, there's been some ideas about the ERAS guidelines, just as in the previous talk was mentioning. Oral immune nutrition should be considered to reduce infectious complications. Antibiotic prophylaxis prevents SSI, and they should be used in the Whipple patients in single-dose manner, half an hour to an hour before the skin incision, and repeated doses in cases of the long duration of the operation. In pancreatic surgery, in our institution, we use cefuroxime, which is initiated the first injection less than an hour before the operation and repeated once if the operation lasts for more than 4 hours. And it is routinely discontinued after the operations unless there are specific indications. And to close, I just want to briefly mention one thing that has been debatable over the years is the fact about the acute necrotizing pancreatitis. So the current guidelines say that the intravenous antibiotic prophylaxis is not recommended for prevention of infectious complications in necrotizing pancreatitis. And the same goes with probiotics. And as far as the fine needle biopsies is concerned, it's not mandatory in the current concept of taking care of patients with necrotizing pancreatitis. So in conclusion, Mr. Chairman, when we are looking at the controlling the microbiota, we'll have to take care of the personnel, patient risk, and equipment factors. No antibiotic prophylaxis is recommended in elective LCCs, FNBs of solid masses, nor in necrotizing pancreatitis. In ERCP, the antibiotic prophylaxis only in patients in risk factors groups, and the antibiotic prophylaxis is recommended in the FNBs of cystic lesions, biliary tract surgery, and pancreatic surgery. And there is various international guidelines and institutional specific protocols that should be followed accordingly. Thank you for your interest.
Okay, thank you for a nice presentation. Any questions from Thorell? Okay, I have one question. How do you think about the indications of some medication, such as probiotics or prebiotics, particularly in surgical patients with preoperative extrabiliary drainage?
The probiotics is something that we don't use too much in our institution. That might be something we'll have to look into in the future, whether they are beneficial enough.
Thank you very much.
So I have one question for the audience, and I'm going to look around. You have to raise your hand, yes or no. Those that don't, I'll take care of you afterwards. So how many of you do use prophylactic antibiotics when you do a laparoscopic cholecystectomy? You see that? How many don't? It should be every other hand in the room. There's a couple guys up there that didn't answer. What do you think about that? You haven't convinced them.
Well, I have to do better in that case. So I don't see any indication in the elective cases.
Thank you very much. Okay, we move on to the third speaker. Dr. Matthew Walsh from USA. His title is Proper Metabolic Control for Pancreatic Resection.
Thank you. Good afternoon, everybody. I saw that this was being simultaneously translated, so I want to thank my translators and also apologize at the rate at which I will speak to try and get through all this exciting information. So we're going to talk about perioperative considerations in pancreatectomy. Although I have a strong interest in nutrition and prehabilitation, I won't have time to cover that. I think what is worthy of talking about right now is the endocrine insufficiency as well as exocrine insufficiency. And as a little spoiler, I'm going to try and give you the impression that you have to pay attention to exocrine insufficiency, which we typically don't, even pancreatic surgeons. So endocrine and exocrine function, you just have to be careful when you're looking at the literature because people may define what is exocrine insufficiency differently. We often talk about endocrine deficiency after a partial pancreatectomy, but we rarely we underappreciate the amount of exocrine insufficiency, particularly preoperatively. And unfortunately, especially in the United States, there's an issue of cost with treatment. So let's first talk about endocrine insufficiency. Especially in the United States, we've had an epidemic of diabetes. It has doubled in the last decade. And unfortunately, a lot of these patients are underdiagnosed. And it is part of what can lead to increased surgical morbidity and mortality in diabetics, increased risk of infection, myocardial infarction, and overall it's up to 5 times odds ratio of increased mortality if you're diabetic. And we think the outcome is partly related to hyperglycemia. So if you look at non-cardiac surgery, 30-day mortality and morbidity, although this study didn't show a significant increase in death, the rates of pneumonia, wound infection, and sepsis were all increased in the diabetic population. Of interest, this, as it turns out, is not always related to hyperglycemia in the diabetics. So if you look at the actual triangles in preoperative and postoperative hyperglycemia, those were normal patients, non-diabetic. So the presence of hyperglycemia is a marker often for sepsis and pneumonia in these populations that can lead to increased mortality, even when it is present preoperatively in the normal patient. And there are a lot of factors that relate to this in terms of perioperative hyperglycemia, and it's incumbent often upon our anesthesiologists to help us control this, especially intraoperatively, and intraoperative control will help reduce the incidence of SSIs postoperatively. So what's the likelihood that you'll have diabetes after pancreatic operations? It does depend if you look at distal pancreatectomy versus PD. Partly it will depend on what type of underlying problem there is. It is higher if it's in someone with chronic pancreatitis versus a pancreatic neoplasm. But you can see it's about 30% if you have chronic pancreatitis. And if you just look at neoplasms, the benign neoplasm versus malignant, it's not particularly much different, interestingly, in terms of just neoplasms. Those neoplasms include IPMN. And you can see in these studies that there's not much heterogeneity between A, which is the top, which is in benign tumors, versus malignant tumors in B, or a combination. And interestingly, if you were to look at everyone who's going to have pancreatic surgery and do oral glucose tolerance tests on them in patients who are not diabetic, you will see that about a third of those who don't have diabetes will test positive for diabetes. And certainly if you have diabetes, that can get worse in almost 50% of patients after a pancreatectomy. But also of interest is not everyone gets worse. If you test them after a pancreatectomy, some people will have improvement in endocrine function because some patients who are abnormal preoperatively in the setting of sepsis or jaundice, actually once you perform the surgery and have them recover, they actually improve, interestingly. So it's not a universal that if you're abnormal preoperatively that you will end up being diabetic. And I think it's important that you, in your hospital, have guidelines on how you're going to treat people with diabetes. This is a published one from our center looking at how you would evaluate them, including hemoglobin A1C. And you need special precautions if you have an insulin pump or if you're known to be diabetic. So in general, perioperative guidelines in diabetics is really try and get your hemoglobin A1C controlled as well as your blood glucose. Intraoperative glucose monitoring should be done by your anesthesiologist. It's important. Some of these will have delayed gastric emptying, and you want to prophylax against nausea and vomiting. So you should consider it in the preoperative setting, I would say, and often anticipate it in the postoperative setting. And interestingly, if you look at survival in pancreatic cancer in those with diabetes and also comparing with tumor size, you see the absolute best survival is diabetics who are not on insulin and have small tumors. Let's talk about exocrine insufficiency. It's much more prevalent if the pathology includes ductal obstruction, so often in head-dominant disease and in patients with chronic pancreatitis. Inherently, if you have insufficiency, it's associated with malnutrition and therefore can be associated with weight loss. And then you can assess this both clinically and with testing by fecal elastase. We did a study through the Pancreas Club that looked at, so these are dedicated pancreatic surgeons, and we asked them how they treated patients pre and post-operatively, and interestingly, less than half, about 40%, actually did treat patients or considered it preoperatively, and only a third gave routine replacement in the preoperative setting in pancreatic surgeons. And I put this up here to highlight not the overall incidence of EPI, but the fact that you can test for it in many different ways. Probably fecal elastase is the single best. But after a pancreatic duodenectomy, if you're checking for fecal elastase, you can see how high the relationship is between EPI, exocrine pancreatic insufficiency, and having done a Whipple. Whereas clinical steatorrhea, you'll see, is about half of the time. So how you assess for this is actually very important. If you look overall at the risk of having exocrine insufficiency, you'll see that chronic pancreatitis and obstructive pathology is the most common overall. And this is highlighted by this multivariate analysis. So you can see the odds ratio of 141 if you have a pancreatic duodenectomy versus a distal pancreatectomy. So it's about 90% versus 20% overall Whipple versus distal. This was shown in our data. This is also our data looking at if you've had a history of pancreatitis at the time of a distal pancreatectomy, you're much more likely to have EPI. And again, obstructive pathology, even in a distal, will show you to have more likelihood of EPI. I put this up here again to show that benign disease, chronic pancreatitis versus malignant disease, there's much more heterogeneity in EPI assessment than with diabetes, partly because there's so many ways to assess for it, but it is much more likely to occur after a PD than diabetes. And this I put up here to show that if you look at fecal elastase, even in the preoperative setting, you'll see that your EPI risk is relatively high and gets worse certainly after surgery. This is for Whipple patients. So this is also data from our institution where we looked at what could be the outcome if you give preoperative enzyme replacement. And I just want to highlight at the bottom that the likelihood of getting enzyme replacement, even in our hands, is more likely if you have a clearly obstructed duct and therefore more likely to have symptoms that will get us to treat them preoperatively. But if you do that, people who are treated preoperatively, interesting, seem to have less fistula risk, including clinically relevant risk and perhaps improvement in their SSI. This is probably very multifactorial, but if you do a meta-analysis, you'll see that at least in our experience, if we give pre and post treatment, we will do better. So what about giving enzyme replacement? Just remember you can't test for fecal elastase if you have watery diarrhea because it'll be too dilute, but you can treat for people on commercial products. And your goal is to achieve 90,000 units per meal. That's if you have no pancreas, so usually you start a little bit lower. And it's important to make sure that you have patients take the medication throughout the meal. And this, I will also highlight, there is a new replacement for tube feedings that you can apply on the tube feeding device. For people who don't respond, you want to add a PPI and consider bacterial overgrowth. And these are the enzymes that are currently available in the United States. We tend to use Creon at the 36,000 dose and usually start with 2 capsules per meal. Again, interestingly, like diabetes, overall survival in pancreatic cancer can be associated with improved survival in all categories with treatment, interestingly. And if you look at odds ratios on the likelihood of surviving after pancreatic cancer, people seem to have as much success with enzyme replacement as they do from having surgery alone and chemotherapy in the adjuvant setting. Lastly, I'm going to conclude by referring to this article of nutritional support by the ISGPS, which I give you as a reference because it has nice guidelines. These are all the guidelines. The ones that pertain to us are that regardless of technique or reconstruction, you should be monitored for both endocrine and exocrine insufficiency, that you should test for fecal elastase, especially in people who are symptomatic, and that once you do the procedure, you should routinely be looking and give replacement therapy if they have symptoms. Probably everyone, as I told you, after a PD is going to require that. And anyone who's not having surgery should, and are locally advanced, should be getting enzyme replacement. And then lastly, steatorrhea, of course, is a common clinical manifestation, but that's an end game symptom once they have actual fat in the stool. And when it's associated with weight loss, that's also an end game scenario. And with that, I will thank you.
Okay, any questions from the floor? No? Go ahead.
Thank you, Dr. Walsh, for that excellent talk. I just had a question regarding patients who you had mentioned that have obstructive symptoms prior to pancreatic duodenectomy, that oftentimes, or sometimes, those patients will recover their pancreatic exocrine insufficiency after surgery. I was just wondering if there is a protocol in terms of measuring elastase levels to confirm whether that is the case or not. Thank you.
Yes, so just to clarify, the improvement in function after a PD compared to pre-op is only through an endocrine function, not exocrine function. Everyone who has poor exocrine function pre-op will have it post-op. Actually, it gets worse. We would test post-op if they're not getting better and we're not sure what the problem is. Specifically, how much do we need to go up in the dose?
Okay. Go ahead.
You mentioned the high cost of this, especially exocrine replacement in the States.
Yes.
Any tricks of the trade for those patients who can't afford it?
So the company, so the average cost for Creon is $1,500. That's American money, not Polish, per month. And the company will help support patients based on means. If they absolutely won't take it, there are some non-FDA approved over-the-counters that I will have patients try. I figure it's better than nothing.
My dog has pancreatic exocrine insufficiency.
Yes.
It costs $10 a month to give my dog pancreatic enzymes that are dehydrated and sold over the counter. $10 a month. So if anybody's interested, let me know. I have no interest in the company.
Do you prescribe veterinary enzymes for your patients?
Any more questions? Okay, thank you very much. Okay, so next speaker, we move on to next speaker. Our planned speaker is Ho-Seong Park, will be replaced to Professor Ho-Seong Han. His title is Nutritional Management for Patients with Postoperative Complications After Hepatobiliary Surgery. Okay, Professor Han.
Thank you, Dr.
Could you
Nabeya
give us a
and
lecture?
Professor. Actually, I was here to fill up the Dr. Bach, so I'm sorry that I changed my title a little. Good afternoon, dear friends and colleagues. It is my great pleasure to speak in this 48th World Congress of Surgery. Today, I will speak about surgical inflammation and outcome, and my talk is related to ERAS as well. First, introduction. our goal of, I'm HPV surgeon, my goal of surgery is same, to reduce the morbidity and mortality is our goal. So we are always think about what is the best patient care in surgery. So this is ERAS. So there are many ways to improve the outcome of surgery. I speak about the inflammation, and one component of ERAS is minimally invasive surgery. Inflammation, morbidity is, I think, is very important. First, acute inflammation was regarded as good inflammation because it triggers inflammation in the cut, bruise, and infection. And chronic inflammation is known as bad inflammation. But today, I speak about acute inflammation is not good, it's a bad. So as you know, chronic inflammation goes to cancer. There are many ways, but one is cardiovascular disease, Alzheimer, and neurological disease, arthritis, many, but it goes to cancer. So as you know, chronic inflammation is a precursor to cancer, is well known. I speak about the impact of acute inflammation on cancer. So to know the impact of acute inflammation on cancer, we have to see the best example when the acute inflammation is coexist with cancer. So, and the mortality and cancer is very important. So I'm thinking about when the condition of acute inflammation coexists with cancer. There are several examples, but I think one is the gallbladder cancer with acute cholecystitis. Another example is common bile duct cancer with acute cholangitis. So I have analyzed data of acute inflammation that coexisted with gallbladder cancer. So this is the graph. The red line is that no inflammation, no inflammation, and the blue line is the acute cholecystitis, and the patient is all gallbladder cancer. If you look at the gallbladder cancer, the patient with the acute inflammation, acute cholecystitis, blue line is worse than the no inflammation. Right side the graph is same. So we can see the acute inflammation has impact on the worst prognosis of the patient. Then we move to the common bile duct cancer. So we analyzed that the cholangitis may impact the prognosis of common bile duct cancer. So if you look at this table, overall survival is related with the inflammation here. So this is the graph. The blue line is the no inflammation, no cholangitis, and green line is the cholangitis, acute cholangitis. If you look at this graph, the patient with cholangitis has worse prognosis. So if two examples, one is gallbladder cancer and common bile duct cancer, the inflammation has a big impact on the survivor. And also the complication has also the impact on the survivor. So this graph shows that the green line is that the patient with the complication, and the blue line is the patient without complication. If you look at the patient with the post-op complication has worse prognosis. So if you look at this graph, the patient with the complication has more metastasis, distant metastasis. And also recently I have studied about CRP and albumin ratio. CRP is, as you know, a well-known surrogate inflammation, and albumin is also a surrogate of nutritional effect. If the CRP albumin ratio is high, it means that the patient has inflammation with poor nutrition. So this graph, the blue line is that the patient has low CRP and good nutrition. The patient is much better in blue line, and it is same in disease-free survival rate. So inflammation and nutrition is very important in the survivor. And recently we have analyzed data of pancreas head cancer. 291 patients was analyzed, and the CRP was used as a marker for preoperative inflammation and cholangitis. So when you look at this graph, when the CRP is more than 1, is green line, the prognosis is worse than the CRP, less than 1. And also, this is same in this survival. The graph more separate. The green line is that the CRP is less than, more than 1, and the blue line is less than 1. So to prove that this occurs, we have studied on the mice model, and we had this study's impact of acute inflammation on progression of metastasis on pancreas cancer animal model. For the peritonitis, we have used zymosan, 1 injection of zymosan and 2 injections of zymosan. This is Z1 is 1 zymosan, Z2 is a severe inflammation, 2 injections of zymosan. The liver metastasis occurs, tumor volume is increasing, tumor volume is increasing. So if you look at this microscopic finding, there are more metastases. So we can say that if inflammation is severe, more metastasis, more tumor growth. So this is related with EMT. So we have analyzed data of MOC1 and epichem, which is a marker of the EMT. So we can see that the marker is increased in the 2 injection of zymosan, severe inflammation, and also 2 injection more MOC1, and also EMT is increased. So as you know, EMT is a very important mechanism for the metastasis. And also we have used fluorescence imaging to see circulating tumor cell. This is the zymosan 1 injection and 2 injection. If you see this graph, there are more circulating tumor cell in the severe inflammation. Then I move to the another component is minimally invasive surgery. So role of immunosurgery in its outcome. So as you know, minimally invasive surgery reduce inflammatory response. So ERAS and minimal invasive surgery combination is very important. As you know, severity of the injury increase from the minimally invasive surgery to conventional surgery to surgery to severe trauma. So the minimally invasive surgery is less trauma. Because I'm a HPV surgeon, I will speak about the role of minimally invasive surgery in chronic liver disease. We have analyzed what's the impact of minimally invasive surgery on hepatocellular carcinoma. So we compared laparoscopy and open liver resection for hepatocellular carcinoma. As you see, this is open surgery, this is laparoscopic surgery. Disease-free survival is same in 5-year survival. You can see that there are no difference in the laparoscopy and open liver resection. Also, overall survival, there are no difference. 5-year survival is 76%, open is 73%. There is no difference. But in morbidity, complication occur in 12% in laparoscopy and open 20%. There are difference. Laparoscopy is less morbidity. But for liver resection, liver failure is very important. If you see liver failure, laparoscopic liver resection was only 3.4% and open liver resection 4.9%. Although the survival is same, the liver failure occur less in laparoscopic surgery. So MIS surgery has a benefit to less in morbidity. So optimal care of the patient, minimally invasive surgery is beneficial, and when we operate, we have to do very meticulous technique. This is a sculpture. Meticulous technique is necessary. So for one example, we have analyzed data of our liver surgery. After liver surgery, sometimes there are liver ischemia. So we want to know the remnant liver ischemia may affect the prognosis. So association of lamina liver ischemia for the survival of HCC patient. In multivariate analysis, only severe lamina liver ischemia is a factor for survival, disease-free survival and overall survival. And we have compared between the severe liver ischemia, yellow line, and minimal liver ischemia. There is a big difference in overall survival and disease-free survival as well. So when you do operation, liver operation, we have to do very precise technique without minimizing remnant liver ischemia. That's why the precise technique is very important, and this precise technique can preserve parenchyma. Parenchyma saving, and this can be performed by the anatomical segmentectomy. This is the report in our institution. We try to do laparoscopic surgery, and we try to do anatomy liver resection. So to reduce morbidity, vascular technique is very necessary. This is the pencil, and this is the lead. Vascular technique is very important, and MIS with the precise operation technique is good for the patient. So as a surgeon, we have to do our best to improve the survival of the patient. This is our team. Thank you very much for your kind attention.
Okay, Professor Han, thank you very much for a nice presentation. Any questions from Thorell? Please, go ahead. Okay. Go ahead.
I don't know if
According
there we go.
the concepts you have described, in your opinion, is it helpful to initiate anti-inflammatory treatments before digestive system cancers? Thank you.
Sorry, may I ask you to repeat your question, please? Sorry.
According to your opinion, is it helpful to initiate anti-inflammatory treatments before digestive system cancers surgeries? Thank you.
It is very important, very important. So actually this is the result. But for cholangitis, I think as you see in the pancreas cancer, cholangitis is very bad for the survivor. So you have to treat cholangitis before the surgery. So and we have to treat to reduce complication as possible. And about the anti-inflammatory agent like Celebrex or something, we are studying about the randomized study of the Celebrex. But my expectation is this anti-inflammatory agent is very good for the patient. Thank you very much. Very excellent question. Thank you.
Thank you.
So I have a follow-up question on cholangitis and CRP. So when exactly did you test for the CRP? Was that at the time that they had cholangitis, or did they get better from the cholangitis and you checked CRP and it was still abnormal before their surgery?
Yes,
in terms of
very good question. So
mortality.
actually, very good question. But in our institution, CRP is a routine laboratory study. So when the patient has a preoperative laboratory study, CRP is included, and postoperative CRP is also included. This study is only preoperative CRP. So actually, postoperative CRP is also important, but postoperative CRP is actually related to complication. So we have to do as our best to reduce complication. This is a surgeon's role. But the preoperative cholangitis is actually we cannot do that. But if there's a cholangitis, we have to treat very quickly. The study about this cholangitis is a preoperative cholangitis.
I guess the point is, should you treat cholangitis until they have a normal CRP before you operate on them?
I don't. It is very difficult to answer because only I know is that elevated cholangitis is bad, but I don't know. We have to wait until the CRP become normal or not. I don't know actually. But for me, just reduce CRP may be enough because you have to do operation as well.
And my last question is, you didn't show a survival advantage in MIS versus open. Did you look for acute inflammatory markers in those patients? Post-op, like CRP or anything that might show that inflammation is actually less because of the technique, or maybe no different?
Yes, it is very important question. There are actually in our institution we don't have any study like that, but there are many literature that show that if we use minimal surgery, the many tumor TNF or interleukin, there are many less level of the inflammatory associated cytokine. So it's a good question. But in our institution, we didn't compare the level of the other inflammation-associated cytokine.
Thank you. Should be last question.
Thank you for the interesting talk. You demonstrated that acute inflammation leads to reduced overall survival in pancreatic cancer. My question to you is, if you were to identify acute inflammation on a preoperative biopsy, would you change your management at all in the form of offering neoadjuvant therapy or postponing surgery for chemotherapy?
So if the patient has cholangitis, you mean?
Inflammation on the tumor biopsy.
Inflammation on tumor biopsy. Well,
Yeah, if you do an FNA of the tumor.
we don't do that. We don't, because I think if we are thinking about neoadjuvant therapy, we have to do biopsy. But if we do the straightforward surgery, we don't do biopsy, because I think if we are thinking about curative surgery, biopsy is not good. I think it may disrupt the tumor, and there may be some tumor spillage. So I don't think if a curative surgery, we don't do biopsy before the operation.
There are two types of inflammation, one from infection, which is cholangitis, and one that doesn't have inflammation in the neoplasm. It's an inflammatory condition in the body. So can you treat an inflammatory, non-infectious condition preoperatively? You mentioned Celebrex, I think.
Yes, actually, Celebrex is for the adjuvant. So if there's there's inflammation, I think Celebrex has a more effective, I think. But in general, actually, for me, acute inflammation assists wound healing and cutting. But also acute inflammation is used in the progression of the tumor, in metastasis on the tumor progression. So I think for even in the normal tumor without inflammation, I think the anti-inflammatory agent may help.
Thank you very much. Okay, let's move on to the next speaker.
Thank you very much.
Next speaker, Dr. James Madura from USA, and selection criteria for metabolic surgery.
Here you go.
Thank you, Dr. Sarr, Dr. Nabeya. Now we're going to change topics a little bit and see how we can select people to make them have poor nutrition, at least temporarily, hopefully. I have no financial disclosures. So we're going to talk about patient selection versus operation selection, and I like to put this in a historical overview because I've noticed in my short career a recurring theme of trying to find an operation, and everybody jumps on the bandwagon. We do a whole lot of operations and then find out a decade later maybe we shouldn't have been doing that operation. That's true of the GI bypass, it's true of vertical banded gastroplasty, true of the lap band. And I think we're now starting to see the long-term results of a sleeve, which will probably result in that same realization soon. And then I'm going to spend most of my time going through some high-quality trials and review of the data. I'm just going to focus, these are all the American Society of Metabolic Bariatric Surgery endorsed procedures. We're just going to talk about the major surgical procedures today. I have another talk tomorrow. We're going to go through some of those other balloons and other novel techniques. So this is the first reported weight loss. It's a GI bypass as we know it. Really was, I think, most commonly performed in this fashion. And we soon learned within a couple years the myriad complications resulting from the malabsorptive state, toxic effects of the stagnant bacteria, and death rates that proceeded along long-term follow-up related to some of these metabolic complications. So we turned to these more restrictive or partial bypass, partial operations, and I'm going to go through these quickly. I know we're a little bit behind time, but this was the gastric bypass and sort of the GI bypass now, 10 or 15 years later, 1978, it was agreed that in contrast to the jejunal-ileal bypass, gastric bypass has fewer long-term side effects, so GI bypass goes away. Then we start talking about gastroplasties in various forms that resulted in what we classically know as a vertical banded gastroplasty. Perform randomized trials saying, well, it's not quite as good at weight loss. There's a subset of patients, but it's easier to perform and it's not as invasive, it's not as radical in operating on the intestines. And nobody does vertical banded gastroplasties. Number one, Roux-I is better, but then the lap band came along. And so we'll move forward. Our patient selection criteria is really straightforward, but I think it's unfortunate that we are somewhat dated. Remember that these guidelines come from 1991. And they suggested that the vertical banded gastroplasty, Roux-I gastric bypass, had enough evidence to suggest that the benefits of the operation outweighed the risks of the operation. And these criteria are what we use today. Body mass index greater than 40, 35 or greater with obesity-related diseases, a well-informed, motivated patient with acceptable risk. This translates into an educational process for most of us, as well as a medical evaluation. And then failed other means of weight loss. Insurance companies often define that in the United States as 6 months of medically supervised weight loss, or show that you've been trying to lose weight for greater than 2 years, or some other arbitrary and ambiguous guidelines. But unfortunately, they have adopted those guidelines. We now have a lot more data, and when you look then and now, 1991, there wasn't a single laparoscopic procedure performed for bariatric surgery. We had basically the GI bypass, which had already pretty much gone away, so it was a gastric bypass versus VBG and then some gastroplasties. There were only about 13,000 operations per year as of 1998. We now do over 250,000 operations a year in the United States alone. We now have laparoscopic, let alone robotic surgery, and a host of bariatric surgeries as well as endoscopic bariatric therapy. So a lot of us think it's time for a new NIH conference to revisit these guidelines, body mass index as a arbitrary, again, guideline. We know there's a lot of data in patients who are lower than 35 who would benefit from some of these operations. So again, the gastric band came along, approval right around 2000 in the United States. Everyone went along and agreed with this almost as good, not as radical, adjustable, reversible philosophy. And I think that the Swedish obesity study sort of started the flow to show that the banding wasn't as good as we had hoped long term. I know these are little different bands than the lap band people have pointed out. But I think this really shows you long term. Here's 15-year data showing the true result in gastric bypasses, maintenance of long-term weight loss and the associated correction of their metabolic issues compared to some of the other operations and controls. So, the band went away soon after this. We started recognizing gastric bypass should remain a primary bariatric procedure because reoperation rates were higher in the laparoscopic adjustable banding patients. And then biliopancreatic diversion as a modification of Scoponaro's biliopancreatic, or with the duodenal switch as a modification of the earlier BPD operations, were now being done laparoscopically, and then evolved into a single stage or a two-stage operation. Some stopped at the first stage, which was just a sleeve gastrectomy, because these patients were satisfied with their weight loss. And so here's the trend that we've been talking about. I don't have good numbers before 2003, but you can see the adoption of laparoscopic banding in the red, and then the demise of the lap band, and now the exponential growth of the sleeve gastrectomy. And remember, these are percentages of operations done, so the percentage of gastric bypasses has gone down, and these are most recent numbers here, even more impressive. but the total number of operations has gone up. So there's still a cadre of us that believe that gastric bypass is probably the best operation. We've continued to do those as our primary operation. So what are we really trying to accomplish with weight loss surgery? It's metabolic surgery, so weight loss, yes, but we really want to look at the resolution of comorbidities and avoid complications and other nutritional issues. So we'll start through some of the data. This is 2011 comparing gastric bypass to sleeve gastrectomy for diabetes patients, and realize these are a little more lighter patients than our typical bariatric 35 BMI. We know that the Asian population suffers from some of the metabolic complications of obesity at lighter weights, and so that's why this was included, and it only includes 12 months of follow-up. But you can see the rates of diabetes remission favor gastric bypass with equal complication rates and a little better weight loss for gastric bypass. I think this is the STAMPEDE trial. This is, I think, probably the best bariatric surgery long-term randomized trial that's ever been done and is quoted. We now have 5-year data, which we'll talk about in a minute. But the main comparison was comparing medical treated patients to the combined sleeve gastrectomy gastric bypass patients. And the conclusions were that surgery is better than medical therapy. But this has also given us an opportunity to break down and do some comparisons between the operations. And if we look at the 1-year, 12-month follow-up, the only significant difference between the operations, so this is gastric bypass, sleeve gastrectomy versus medical therapy here. And you can see the highly statistically significant improvement in all of the measured outcome, both primary and secondary outcomes. But the only statistical difference between the operations, gastric bypass and sleeve, was better weight loss with the gastric bypass at 1 year. There were some trends maybe, but nothing statistically significant at that point. Adverse events at 12 months, they didn't have high enough power to really compare these, but they were basically the same, including some of the things that we thought, like the anemia and metabolic consequences of bariatric or of the gastric bypass that we've been concerned about, were really very similar between both of those operations, at least at a year. They followed this up with 3-year outcomes. We now have statistically different characteristics between the operations, the diabetes, gastric bypass performing better, and a further divergence of the long-term weight loss maintenance in favor of a gastric bypass. Again, when we look at, I have this in graphical form that looks a little bit better comparing between the operations. Again, long-term nutritional complications, very similar between gastric bypass and sleeve gastrectomy, as were the complication profiles. So this is a slide that's a graphical representation of that comparison of diabetes. And when you look at, this is the important slide here, and what this darker box is, 45% of the patients at 5 years did not take any diabetes medications, and that's a gastric bypass, compared to 25% in the sleeve gastrectomy. These are various forms of medication. So we know definitively that long-term a gastric bypass is performing better in the diabetic patient than a sleeve gastrectomy. Again, 5-year complication, little higher rate of ulcers. These are not powered to really discern the difference. And again, we start seeing higher rates of gastroesophageal reflux in the sleeve patients. So this is not even hot off the press. This is published online ahead of print. This is a resource or a claims-based cohort looking at the effect of the two operations in a large number of patients with regards to diabetes resolution. You can see the numbers there. Gastric bypass had an 86% lower total diabetes medication dose than the sleeve gastrectomy patients, and the patients with the sleeve were less likely to match gastric bypass to continue all diabetes medications. So long-term data, again, showing this was 2017 at the ASMBS meeting, meta-analysis, 2,300 patients, 24%, as high as 36% in-series failure, defined as less than 50% excess weight loss with the sleeve gastrectomy. Those numbers are traditionally around 15% for a gastric bypass. And then the reflux question with the sleeve is getting a lot of attention as well. This is 2017. They followed 43 patients for, you can see, 130 months. And when they looked at the outcomes, surgical outcomes, 16% of the patient, or 6 patients, 14% were converted to a gastric bypass because of their severe reflux. Another 10% had symptomatic reflux but were not yet converted, and 10 of those patients were converted for a weight loss failure. So almost half of the patients had been converted after a sleeve gastrectomy for one reason or another. And then they performed endoscopies on those patients, those 43 patients at least, found new hiatal hernias in as high as 45%, and new Barrett's metaplasia, very concerning, at 15% with sleeve dilatation, probably responsible for the long-term weight regain we're now starting to see. Another study looking at the same concerns, 110 patients, 58 months of follow-up, reflux in 68 versus 34%, sleeve versus bypass, proton pump inhibitor use, hiatal hernia 74%, bile-esophageal reflux documented 74%, and new Barrett's in 17%, so consistency between these two studies. When we looked at the SM-BOSS trial, 217 patients, excess body mass index loss about the same, but 32% reflux after sleeve. Reoperations, those were mostly minor things like gallbladders, umbilical hernias, or trocar site hernias. Not really, I think, clinical difference between the operations, and again, better resolution of diabetes with the gastric bypass. The sleeve pass trial we're familiar with, excess weight loss better, diabetes resolution better, dyslipidemia better, hypertension better with gastric bypass. So interestingly, I think that data is now maturing with very good studies showing the differences between the operations, and I think help us select those patients that may be better served with one operation or another in those groups of diabetic and reflux patients especially. This study, in case you don't know, came out in the same edition of the New England Journal of Medicine in 2012 as the one-year post data from the STAMPEDE trial. And this is comparing a gastric bypass and BPD to a medical group, lower numbers of patients in each group, but again, a severe diabetic population, body mass index 35, hemoglobin A, and they had 2-year follow-up. And interestingly, the glucose numbers were all in favor of, again, this is comparison between the operations over here. These are comparisons between an individual operation and medical therapy. So both operations, much better medical therapy. And a sleeve was better, or the biliopancreatic diversion duodenal switch was better at some of these hemoglobin measurements or diabetes measurements. Not a whole lot of difference with blood pressure, weight loss, and waist circumference. But we're already at 2 years starting to see some of these concerns with the malabsorptive operations, the hypoalbuminemia, osteoporosis, and osteopenia. So in conclusion, I think if we really are just talking about these metabolic outcomes, the biliopancreatic diversion with the switch is clearly the most reliable weight loss. They have the lowest failure rates, the best results in diabetes treatment, but again, the highest metabolic and surgical complication rates. I think the sleeve at this point in time we know is less appropriate for patients with diabetes and reflux. It probably should be avoided in those populations. And it's still my opinion that a gastric bypass has the best results to risk ratio. So thank you again for having me.
Thank you very much. We don't have time to receive any comment. Thank you very much. So let's move on to the last speaker, Professor Anders Thorell from Sweden. His title is Avoiding Complications in Bariatric Surgery.
We're going to go a little over time. Please don't leave. And those of you that have questions at the end, the speakers will stay around for about 10 minutes, kind of over there. Come and ask them questions, okay? Great.
Thank you very much, Mr. Chairman. I'm sorry that we are getting out of time, but I'll do my best to catch up with that. And I would like to take the opportunity to thank the organizers to inviting me to give this presentation on complications after bariatric surgery. These are my disclosures. And this is only to remind those of you who are not really into bariatric surgery on a daily basis that only a couple of decades ago this procedure was associated with high morbidity and even also mortality. In fact, a long recovery time and usually performed by the open approach. This slide was mentioned in the former presentation. This is only to illustrate that we are approaching worldwide 700 procedures annually a couple of years ago, and I think it is actually approaching 1 million about this year. So today, these procedures are performed by minimally invasive techniques. Patients are being mobilized early, and they are allowed immediate oral intake, and they are discharged very soon after the operation. And in terms of evaluating means that might be used to reduce the complications after any type of surgical procedure, they could be divided into general as well as specific items. The general being associated with factors such as improving the surgical technique and to increase volumes and specialization at certain centers, and the specific being different, obviously, depending upon what type of procedure we are facing at. In order to illustrate the changes who could be considered as general, I will share with you some data from the Scandinavian Obesity Registry. This was launched in approximately 15 years ago and then is now capturing data from Norway and Sweden. They are followed at these time points that's given in this slide, and we have a very high coverage rate, and that has to do with the reimbursement system in Sweden, that you are not getting reimbursed unless you report to the registry. All users have access to data, and by applying to a steering committee, you can do research if you wish, as long as you have an ethical permission for that. And annual reports are published on a hospital level, so it's a complete transparency about the results for these measures. So these are the data during the last year for the use of laparoscopic access. You can see in the blue line increased up to 100% the last years. At the same time, the mean operating time as well as the mean primary hospital stay has been reduced by well over 50%. Now, does this translate into improved results in terms of complications? Well, without being able to show any causality, this slide shows that at the same time there has been a simultaneous reduction in any complication, which is the green line there, and readmissions, which is the blue line. And for specific complications, as shown in this slide, you can see that there is, again, a well over 50% reduction for bleeding, leakage, and deep abscesses. And for medical complications, there is a similar picture, although not as pronounced as for the surgical complications. So it really seems to be a relationship between the degree of technical skills and the volumes and the results in terms of complications post-operatively. ERAS has been mentioned a couple of times this day, and this is obviously also something that might contribute to the improvement in terms of complications. All these items are acting in concert in order to reduce the stress that is being exposed to the patients and will also reduce complications. But as had also been said here, we need to confirm that this is also applicable in various settings. So therefore, a couple of years ago, we published the guidelines, ERAS guidelines, trying to find evidence for all of the various items. And I will give you a few examples on some of those. The first one is the use of laparoscopy, and the group found 3 RCTs convincingly demonstrating that there is an improvement in terms of complications as well as for rehabilitation post-operatively. There might be one potential disadvantage with the use of laparoscopy in gastric bypass, because it might increase the risk of formation of internal herniations, because it is more prone to produce less adhesions compared to the open technique. But nevertheless, based on these data, the group recommended that laparoscopic approach should be used, and that is with a high level of evidence and a strong recommendation grade. Another issue is preoperative weight loss. That is also included in the bariatric guidelines, and there is a tradition since a long time, because based on the fact that it is known that a couple of weeks of low-calorie diet will reduce the liver size and the intra-abdominal fat volume, that it should be recommended a period of low-calorie diet or very low-calorie diet for a couple of weeks before bariatric surgery. But if that has any impact on post-operative complications was not previously known. So we addressed that by using data from the Scandinavian registry. We captured approximately 20,000 patients in which there were numbers of the preoperative weight loss available, and we divided these patients into percentiles depending upon the preoperative weight change. And as you can see, for the lowest percentile, there were not very much of a weight change at all, whereas in the 50th and the 75th percentile, there was a 5 and 10% reduction in total weight loss, respectively. And by doing multivariate analysis and adjusting for confounders, we found that compared to those patients who did not lose weight, there was an approximately 15 to 20% reduction for any complications. And if you looked into the specific complications, it was the same picture, 25% reduction for anastomotic leakage and 35% reduction for deep infections. That was only in the highest percentile. But for the minor wound complications, there were a 50% reduction in both of these. So there seems to be a sort of a dose-response relationship between the preoperative weight loss and the reduction of risk of complications. So this is really indicating of an effect, but we were also able to address that in a randomized study in which we find, to save time, I will show here that we found the same reduction of complications by approximately 50%. Finally, some words about the internal herniations after laparoscopic Roux-en-Y gastric bypass. This is a situation which neither of us would like to find ourselves in, with the need of resection due to ischemic small intestines, which is associated with very high and severe morbidity and even mortality. These are the potential sites for internal hernia formation. The first one is beneath the enteroanastomosis here. The second is Peterson space, and the third is if a retrocolic roux lymph has been created also in that space. It was not really known if it is possible to reduce the risk by closing the mesenteric defects during the operation. Before, it was suggested that that could also be associated with complications by itself, and maybe it is possible that by time when you lose weight, there will be a small opening which is even more dangerous than the one that you leave if you don't do anything at all. So we address that by performing a register-based randomized trial when we use the register for including patients, to randomizing patients, and to follow up. And by doing that, we were able to follow up them to 100%. And we were able to follow 1,250 patients in both groups. And these are the intraoperative results. And not very surprisingly, there was an increased operating time in those who had their mesenteric defects closed, but otherwise no difference in the perioperative period. But for the early complications, there was a small, however, significant increase in complications in those patients who had their defects closed. And that was mainly accounted for a need of operation for small bowel obstruction early on after the operation. But as you can see, over time, the lines are crossing each other in favor for the closed group, approaching approximately 50% reduction of need of operation after 3 years. And if one looks into the specific reasons for the obstruction, the early time was due to a kinking of the enteroanastomosis, and later on it was due to internal herniations. So this seems to be an improvement in the rates of internal herniations and need of small bowel obstruction at the cost of a small amount of early operations post-operatively. And if you look only to the internal herniations, you have the results there very convincingly demonstrated that that will reduce the risk for this type of complication. So to sum up that, I would like to say that complications have been reduced by the use of more skills and less invasive procedures. And in order to avoid it further, we have to take in consideration not only the general, but also the procedure-specific features that could be addressed. And for the future, I'm convinced that in order to further improve the results after bariatric surgery, we need to really address the patient selection for each procedure in order to avoid these types of long-term complications. And another important challenge for everybody involved in bariatric surgery is obviously also the follow-up, which is necessary in order to avoid the same type of complications. Thank you very much for your kind attention.
Does anybody have a question? I'd like to make one point. In the United States now, we have fellowships for training bariatric surgeons. They learn to do these laparoscopic approaches with an experienced surgeon. The mortality is now 0.3% for a gastric bypass in the United States. These fellowships have revolutionized the care. Is it the same way in Sweden?
Well, we do have specialized fellowship for that. That is included in the training for general surgeons. But if you are going to have a position on a bariatric center, you certainly need to do exactly what you say and starting it stepwise, doing one part of the procedure in the beginning and then increase and finally doing the entire procedure.
So I'll encourage anybody that has questions. Go ahead, one more question.
Hello, Jonathan from Malaysia. Can I know what's your take on laparoscopic cholecystectomy at the same setting as bariatric surgery? Prophylactic cholecystectomy.
No. We are not doing that regularly, only on those who have symptomatic gallstone disease, and then we usually recommend to do the cholecystectomy as a previous procedure and then do the bariatric procedure.
So anybody that has questions, the speakers will be here for about 10 minutes. Come on down and ask them, but the session's formally over now, okay?